Melanie Fontes Rainer from the Attorney General's office. She serves as Special Assistant to the Attorney General and as his Chief Healthcare Advisor, former Senate Healthcare, Education, Labor, and Pensions Committee staff person. So let's give her a round of applause and welcome Melanie up to the stage. So thank you for being here. I appreciate that you have joined us, and I think that there's a lot of interest and in some quarters anxiety about the Attorney General and his regulatory role. So I appreciate you being here. Why don't you first just kind of sketch for us the stuff that the Attorney General's office has on its plate right now. Obviously there's some higher profile lawsuits, but what are the things the AG's office is doing? Where does it see its role in terms of plugging into the healthcare conversation?
Sure. Thank you. And good morning. The Attorney General Becerra, he is very focused on, increasing access to affordable healthcare. As the Attorney General, you get to wear a hat where you protect health, safety, and welfare of Californians. And so he has a constitutional authority and duty to protect that. That has been done over the years by different AGs in different ways, and in particular in this time under this president, we've done a lot of federal resistance. And I heard the senator mention the ACA, my boss, the AG, was quite instrumental in passing the Affordable Care Act, and he feels very passionate that people have access to health care now, and we cannot let that go, and we cannot let those consumer protections go away. And so it's been a big priority of ours to protect that. And in that, in many ways, is protecting Californians, right? So things like, a birth control regulation, which would allow employers to deny women birth control. We were able to secure a nationwide injunction to stop that. There's a Texas lawsuit, thanks. There's a Texas lawsuit where a bunch of attorneys generals are now suing. I know that we defeated repeal and replace, and I heard that in the previous iteration. But you know what? It's not dead, right? We have the Texas Attorney General has filed a lawsuit in the state of Texas, in the Northern District of Texas, with a judge who is hostile to the Affordable Care Act, with 19 other AGs and governors to repeal the ACA, because what his argument says is that, hey, the individual mandate penalty is $0 now, therefore it's no longer a tax, and the law, the ACA, 8 years later, is unconstitutional under NFIB versus Sebelius. Mm-hmm. So, that to us we think it's dangerous, and we think it's not quite legally sound. And so we've, motioned to intervene in that case, and we're pushing very hard alongside other Democratic attorneys generals, and in some mixed states, right, like Kentucky and Virginia and Iowa, and some of those places where, you have mixed representation. It's not just a solid, everyone loves the ACA.
To oversimplify on that Texas Attorney General case, but I think it's oversimplified, but I think it's generally accurate. I think the NFIB versus Sebelius case, and I'm not a lawyer, so you correct me, argued that a lot of this stuff hung together. I think the Obama administration argued that this all hung together, and that if you pull out, one thread of this, it starts to all unravel. And the individual mandate was a big part of that argument and decision, so that it seems like Attorney General Paxton in Texas used the word dangerous. It seems like this is now a legitimate legal question. We may have our opinions about how we want it to get sorted out, but it seems like this is a newly, maybe equally as legitimate legal threat to the ACA as was NFIB versus Sebelius. Would you put those two cases on equal footing, that they are both sort of equally dangerous in a way that some other cases have not been quite as strong?
Yeah, listen, I think this is more in line with King versus Burwell, right? King versus Burwell, if everyone in the room, I'm sure, remembers, right? You work in the healthcare field, you remember that there were these 36 states that had marketplace participation through healthcare.gov, and those states had millions and millions of people who relied on federal tax credits. And all of a sudden there was this argument that, oh, well, glitch, we don't get to get the tax credits any longer, which would have caused total chaos in the healthcare system, right? It would have left millions of people without health insurance. It would have left the uninsured populations higher for the states to pick up, care. I mean, the individual market wouldn't have worked. And, this case, you're right, they do argue under NFIB versus Sebelius. But, I think to say that just because the tax penalty for the individual mandate is now $0, that it's no longer a tax, I don't think that's valid, right? When Congress passed the tax law last December, right, they very intentionally dialed down the penalty to $0. However, they kept all of the statutory language in place for the individual mandate. And so by doing that, they made a very conscious choice to leave that there. Now, I understand that was done because of the way that they jammed that through the reconciliation process, but let's just call a spade a spade. The text of the mandate is still there, and I think Congress reserves the powers to dial up, to dial down penalties.
Interesting. So even though they might have wanted to repeal the whole thing because of Senate reconciliation not being able to get to 60 votes, just going down to 0, they may have kept in the logic for that obstructs Paxton's case.
Yeah, I mean, this is like King v. Burwell on steroids if it goes through, right? Like, this isn't just tax credits. This is Medicaid expansion. This is money follows the person, the community first choice option program, all the Medicaid reforms that we made as part of the ACA. This is the Medicare donut hole, protecting our seniors. This is, the Innovation Center, all the reforms we're doing with private and public payers. This is the public health reforms, right? The Public Health and Prevention Fund, which funds serious things like immunizations and, infectious diseases and helps states prepare for the inevitable worst, right? So that they can prevent that. This is all of those things, right? And if you look at, we had one of the declarations which we provided as evidentiary support for this lawsuit or motion to intervene, if you look at the dollars just to the 16 states, including California, which is billions and billions of dollars, I mean, it is like $500 billion that these states would lose, which would totally upend the healthcare. I mean, it would be legally deficient. It would totally upend the healthcare system in a way that I don't think anyone. This is repeal without replace, but through the courts.
So tell us about the Sutter lawsuit, and I know this is you don't try legal cases in conference settings, and that you're not the lead on the case. I think I'm interested just in a general explanatory baseline sketch of it, and then I'm really interested because I think the audience is interested in how does this apply to some of the other markets in California where recent studies suggest many of them are highly concentrated. In fact, 44 out of 54 counties with a hospital are considered highly concentrated, at least from this recent study from Cal Berkeley. So baseline sketch of the Sutter lawsuit, and then how does it apply to other parts of the state?
Sure, and I will just do a disclaimer at the front end. This is pending litigation, so I'll keep to what's public in the complaint. Yes, our office our office in fact worked with the Petrus Center on that report. I know Professor Schleffler is going to be on a panel later. This isn't just a California problem. This is a problem across the country, right? Where we see, a tie to market concentration and high prices. And our office for a while looked into Sutter. We looked into other systems as well, but we allege that Sutter's market in our complaint that their market competition, their anti-competitive practices are closely tied to their market concentration. And as a result, I think that the Petrus Center study showed that prices for the same inpatient procedure, unadjusted for like regional variation, were 70% higher in Northern California than they are in Southern California. Not having to do with, that's not a quality increase, that is not a need for cost, that is just a market concentration feature, right? And our office, through AG Lockyer, was part of the Ultibate Summit merger, and so this is sort of the next step of that, and in fact, as part of that, this judge was aware of some of these practices, and so it'll be interesting to see what happens.
If I recall correctly, one of the statutes that the Attorney General is alleging Sutter has violated is that, please correct me if I'm wrong because I'm doing this based off of secondhand knowledge, that providers should not or cannot contract for their entire system that they have to be able to contract in a sort of region by region basis or institution by institution, facility by facility basis. A, is that accurate, and clarify, please? But B, that is a relatively common approach, maybe not in a formal way that would violate the law, but in terms of trying to find organizational alignments between payers and plans across multiple sectors. Where does that start to get in trouble with statute? So do I have it right, clarify, and how else does it apply?
Sure. So I think you're referring to the all or nothing contracting, right, on a system-wide basis. And yes, our complaint alleges that that is a practice that is used by Sutter. And I don't dispute that others are potentially using it. I think we have seen a successful model that has been untested, and so as a result, others are picking up on that. I think what that means for self-insured employers and others is that they are forced into system-wide contracts that arbitrarily force up the prices. So, I think that's one of the things we do allege in the complaint. It is something we think is a problem. And in fact, there's a bill, right? Senator Monning has a bill. It was up last year that also deals with this.
Mm-hmm. So where do you think the line is? In other words, we have a lot of people in the room who handle contracting or are at a strategic level that inform contracting. Should everyone stop what they're doing and read case law or read your motion? Or is this the kind of thing that will get worked out over time and that, as you say, it's not yet been tested or you're testing it now and we'll see what the judge says. How do you counsel, as the attorney for all of these organizations, how do you counsel them to navigate this question?
So I won't, with all due respect. I will say, I'm not allowed to do that, so hi, thank you. Please write that down. But I will say, it isn't just the one, it's not as if the argument hangs on that one piece, right? It is the sort of all or nothing pricing. It is excessively high out-of-network, that alleges excessively high out-of-network pricing. There's some transparency measures to how data is released to the public. And then, that there have been some practices in place to make sure that those practices stay within that organization. So I think it's sort of the entirety of it, which is, we allege is a violation under the Cartwright Act. We don't know, right? And one of the reasons it took us a while to bring this suit is because, we're in uncharted waters a bit, right? And so I think, everyone should be watching this case. We're trying to test the waters. There's a case in North Carolina that folks should be watching as well. But, I think we're in uncharted waters a bit.
Interesting. Do you think that it's, that we'll see more of this, not just Attorney General activism vis-a-vis the healthcare sector, and not just in California, but because this issue of healthcare generally is so difficult, and Congress with a strong majority in the Republican conference has not been able to do anything really on this, and it took an uncommon amount of Democratic majority support in 2009, 2010, to do something. Many would call half a loaf rather than something more ambitious on the Democratic left. Is the regulation and policy making responsibility of state government and maybe federal government falling to attorneys general to do this because the complexity might be beyond most legislative or congressional majorities?
That is an interesting question. I would say the AG the AG can, defend laws and push forward legal theories that potentially test the envelopes with, the possibility for, big injunctive reliefs, right? Which are, we've seen those before in litigation like Volkswagen, for example, right? Where you get broad injunctive release outside of monetary damages. So I think that is a part of it. I think what we're seeing right now is, you're right, that we have a U.S. Congress that largely can't do anything on healthcare other than like opioids, where everyone sort of agrees there's a problem, let's do something. But at the outset, you have, a market stabilization package that's just sitting there. You have repeal and replace for over a year, right? Like when I worked in Congress, my last thing I did was work on repeal and was sitting with the parliamentarian and making these arguments. And the last day was when Paul Ryan had pulled, at the start of this, when Paul Ryan had pulled the House bill. And to Democratic staff at the time, we were shocked because the idea that the House representatives, which is dominated by the majority, that they couldn't get this bill through was shocking. And so I think you're right that it's sort of new waters, but I think what we're seeing is states like California and others take on things like prescription drug costs, transparency in healthcare, other things, right? Like we're seeing states take bites at the apple, and they're testing these things out. And then we're also seeing those things then head over to court. And so, I think you're right that the states are the laboratory of experiments and development, and the AG, I think, is a part of that.
Yeah. And the judges that ultimately will write the case law, right? I mean, the AG has to sort of work within statute, but the judges at all bench levels get to write policy and law. Should that be a concern for healthcare folks? I mean, does the healthcare community need to pay more attention to Superior Court and District Court judges?
I think they should, and I think a lot of you already are, right? I think, especially with the state legislatures being so active across the country on healthcare policy, I think certainly watching what's happening in the courts is important. And quite frankly, I do think on the federal level, right, the role that, our AG, California's AG has taken alongside some other states, I think that is unprecedented. I mean, it is the flip of the Ken Paxton model, right? That's his name, right? The AG of Texas. Sorry, I forget. But, it is the flip of that model, but in a way where, it is protecting the law. So, absolutely. I think watching, and I think a lot of you in the room we've worked with, and we're very appreciative of your help. I think this isn't just we wake up in the morning and we're like, let's go sue Donald Trump. It's we wake up in the morning, we see, oh, what did they do today? Oh, they rolled back this reg, or oh, this new lawsuit happened. Okay, let's call our local health insurance companies or hospitals or whatnot, and let's figure out what the impact of this is and how hard this is going to hit people of California, and let's work with them on figuring out a path forward.
Very interesting stuff. I think this is, like you say, totally uncharted territory. So thank you for being so flexible, but thank you also for being so candid. Let's give Melanie a round of applause also.